Let's now discuss sodium reabsorption mechanisms by the kidney. Sodium reabsorption mainly occurs in 4 sections of the nephron: the proximal convoluted tubule, thick ascending loop of Henle, distal convoluted tubule, and connecting and cortical collecting duct. Here, we will discuss each mechanism in greater detail. In the proximal convoluted tubule, where approximately 60 to 70% of the filtrate is reabsorbed, sodium reabsorption occurs by both passive and active mechanisms. Passive mechanisms are both paracellular and via channel. Sodium follows an electrochemical gradient maintained by a sodium pump termed the sodium-potassium ATPase, located at the basolateral membrane, which results in low intracellular and high extracellular sodium concentrations. The gradient also enables the reabsorption of other solutes, as sodium serves as a co-transporter. Sodium-glucose co-transporters, also known as SGLT2s, reabsorb 100% of filtered glucose with sodium until the patient exceeds the channel's absorptive capacity, as is seen in uncontrolled diabetes. Sodium-glucose co-transporter 2 inhibitors, also known as SGLT2 inhibitors, like empagliflozin, dapagliflozin, and canagliflozin, inhibit these co-transporters, resulting in sodium and glucose remaining in the lumen. High sodium and glucose concentrations in the lumen create an osmotic diuresis driven by these concentrations. This medication has been demonstrated to be protective in chronic kidney disease and cardiovascular disease. The active transport of sodium occurs through the sodium-hydrogen exchange antiporter, also known as the NHE3. This exchange is facilitated by the mechanisms involved in bicarbonate, also known as HCO3, reabsorption, which requires carbonic anhydrase activity, thereby maintaining bicarbonate and hydrogen ion concentrations intracellularly. You will learn this channel activity is modified by various intrinsic factors like angiotensin II and extrinsic factors like specific medications. Perhaps the most widely known is acetazolamide, which is a weak proximal tubular diuretic. It inhibits carbonic anhydrase, preventing the reabsorption of sodium and bicarbonate. This results in a net loss of sodium bicarbonate in the urine and subsequent metabolic acidosis. At the loop of Henle, sodium reabsorption occurs at the thick ascending limb. Approximately 25% of filtered sodium is reabsorbed here. This section of the tubule is impermeable to water. Reabsorption of sodium occurs via the sodium-potassium 2-chloride co-transporter, aka NKCC2. While the solutes are passively reabsorbed, the process is driven by the sodium-potassium ATPase, present in the basolateral membrane, maintaining the low intracellular sodium concentration, enabling sodium reabsorption via electrochemical gradients. Loop diuretics like furosemide, budesonide, and torsemide are potent diuretics that inhibit the NKCC2 transporter, resulting in urinary sodium and chloride losses and effective diuresis. While potassium is also lost here, it is believed that the greater driver of potassium loss relates to increased distal delivery of sodium, which we will discuss in future potassium modules. The distal convoluted tubule contributes to fine-tuning of sodium reabsorption. Again, a sodium-potassium ATPase on the basolateral membrane maintains low intracellular sodium concentrations, driving the electrochemical gradient for sodium reabsorption via the sodium chloride co-transporter, aka NCC, on the apical membrane. Thiazide and thiazide-like diuretics are common calcium-sparing antihypertensive agents. They inhibit the NCC, resulting in impaired absorption of sodium and chloride and resulting in their urinary excretion, driving the diuresis. Patients can also lose high concentrations of potassium in the urine. We focus on the calcium-sparing and potassium-wasting mechanisms in the thiazide and thiazide-like drugs in later modules. Additional fine-tuning occurs in the cortical connecting tubule and collecting duct. Again, The sodium-potassium ATPase is present at the basolateral membrane, maintaining high intracellular potassium concentrations and low intracellular sodium concentrations, which enables the electrochemical gradient. The epithelial sodium channel, also known as ENaC, is located at the apical membrane. Reabsorption of sodium enables the secretion of potassium through the RAAS channel, thereby maintaining electroneutrality. The collecting duct is the aldosterone-sensitive section of the nephron. Aldosterone is a mineralocorticoid that serves to stimulate the reabsorption of salt by the kidney in states of low effective arterial blood volume. Aldosterone functions by upregulating sodium-potassium ATPase activity and upregulating the number of ENaC channels in the apical membrane. This results in increased sodium reabsorption. This also results in increased potassium excretion, simply through the maintenance of electroneutrality. Mineralocorticoid receptor antagonists, also known as MRAs, are potassium-sparing diuretics that block the activity of aldosterone at the mineralocorticoid receptor. Downregulating the sodium-potassium ATPase and ENaC channels impairs sodium reabsorption. A side effect is hyperkalemia as a result of the reduction of potassium excretion. Examples of MRAs include spironolactone, eplerenone, and finerenone. Amiloride and triamterene are two less common diuretics that target the ENaC channel, impairing sodium reabsorption, which drives the diuresis. Similar to MRAs, amiloride and triamterene are potassium-sparing and have a side effect profile of hyperkalemia. In summary, sodium reabsorption occurs at four main sites within the nephron: the proximal convoluted tubule, the thick ascending loop of Henle, the distal convoluted tubule, and the cortical collecting duct and connecting tubule. Not surprisingly, these are also the locations of our common diuretics as outlined here.